is going to talk, just continuing with the imaging stuff, right? And it's going to talk about finding the correct answer. So most of us will be doing supervised machine learning. If you're not doing supervised machine learning, you still kind of need to figure out your clusters and what they mean. So you will need to figure out the ground truth. There's quite a lot of debate about whether you should be calling this ground truth or they should be reference standards. And but for these purposes, we're going to refer to them as the ground truth. But this is the variable that you're trying to predict. And I just want to go through using chest X-rays because and just sort of how do you determine what you want to do? So when it comes to medical imaging, there are three sort of things that you can do. And when I say medical imaging, it tends to be the same, whether you're doing chest X-rays or you're doing retinal scans or you're doing dermatology images, right? That's the one thing about learning here, because you can reuse things that you learn somewhere else. And so you can do a classification. Here you just give a probability test, right? So here you say there is tumor, no tumor, right? So, and you give the percentage for that. And then you can draw a bounding box, right? And these tend to be, and the reason why you decide to do one versus another tends to be about time and cost. It's very expensive to have radiologists do the labeling for you. And to be honest, most of them don't enjoy doing the job anyway. So Harry can give real world experience of doing something like that. And then there is segmentation. So in this, these are brain MRI images. This is a FLAIR image and this is a T1 image. And there's an abnormality here, the white stuff, and you're just drawing a box around it, or you're doing the segmentation and segmenting every part of the image. So you're either doing a classification task, a detection task, or a segmentation task, okay? Those are the three things you do in medical imaging. And the most advanced is the segmentation, requires a ton of time for the radiologist to draw things for you. Now, I will say that with the, if you've heard of an algorithm from Meta called SAM, which is like segmentation. People have tried to build segmentation models. So if you go to the Mikai website and look at the workshops and the competitions, you can see sort of like some of the data sets and the challenges that have, you know, like said, here's a total body segmenter. Now, for people who are working, for example, in very small spaces like the throat, right? Those are very finite things to draw, and those tend to be very challenging. And our own work, when we've tried to use just for body composition just means you're looking at the distribution of fat, muscle, and you know, there's quite a lot of papers published on that. Frank found it very difficult to reproduce them, which was also a little bit surprising to me because there's quite a lot of work being published on this, but just segmenting muscle versus something else remains a task. So there is an opportunity for automatic segmentation. So, you know, in terms of the history of labeling chest X-rays, the first this is not the first data set. The first one was actually from Indiana University from a chest X-ray. And there's also one from China looking at tuberculosis. But one of the most widely used data sets is really this NIH data set. So if you, and it's called this one by Wang, and it's called the chest X-ray 8, you know, data set. And essentially, it has around 100,000 frontal images from 32,000 unique patients, and you know, they use natural language processing for labeling. And I'm going to sort of go in a little bit. And these are the 8 conditions that they said. So atelectasis just means that the lung is not expanded, right? So it appears as white, very difficult sometimes to differentiate from a pneumonia. And then you can have a big heart, so that's called cardiomegaly. You can have an effusion, which just means you have fluid around your lungs. And so you can see sort of where most of those would be. You can have an infiltration. An infiltration, can be also a pneumonia. And you can see sort of, I'm interpreting them from some of the language that radiologists use. You can have a mass that tends to be leading towards a cancer or something like that. you can have a nodule, and the difference between these two is usually size, when you call one a mass or a nodule. And then you can have pneumonia. Pneumonia is really a clinical diagnosis, but some people will say that this is pneumonia, and pneumothorax just means you have air around your lung. So these were the 8 data sets, and you can see why they also generated a lot of a lot of debate. One, because when it comes to downstream, for example, if you have an effusion, okay, and just let me know if I'm moving too fast, okay? I know this is, just say slow down. But if you have an effusion, which is fluid around your lung, right? Something has to collapse to create space for the fluid, right? So it's not unusual to find fluid and atelectasis, right? And so there is some element of label correlation. But the way they selected these labels, they just asked the radiologist, what should we label our data set? And once that happened, they went to the PAC system. Now I can say PACs, and I hope most of you remember the talk from yesterday. So the PAC system, and pulled, you're just looking at the reports. Sometimes we send Chad on this rabbit hole and say, send me reports with infiltration or pneumonia, something like that. And then you get those reports, and then you now start to apply natural language processing techniques for them. And so what they were trying to show here is that if you could pair their chest x-rays and the images and their reports. And so this is the first thing, because radiologists are expensive. What people use to label reports are the radiology report, and I'll show you an example of that. And then to label what was normal, they would say, all these images don't have these 8 categories, so now I'm going to label it as normal, right? So it's like, if you're missing these 8 labels, then you're normal. But that's a big assumption, right? Because if you have a category that's not here, you could label a normal X-ray, which is abnormal. Does that make sense? Okay. So here's a radiology report, right? Every picture should have a report. There are parts of a report. One of them is the study that describes the study name. So you remember, DICOM metadata is very, very dirty. You have to verify it. This has been a painful lesson for us, including some of the tricks that we've used for the chest x-rays, is to even look at the number of images in a jacket, number of instances, right? In a jacket, in a patient jacket, right? So you can think about like a folder. And if you find, well, this chest x-ray data set per patient has like 10 images in the same day, something is wrong, right? So just doing something like that. So either some other images are merged in there, right? They cannot all be chest x-rays, because most of the time you only have like 2 AP and lateral view, and then maybe a Clahi, like that bone window view that Mali was showing. So if you just even look at the data set itself, most of the time the data set you're using is like PNGs. But for us, if you're looking at the MRE data set, if just by looking at the number of images per accession number can give you a sense of whether there are errors or outliers. And those are easy ways to just go back quickly, get those images and show them to someone, or you can look at them to just make sure to see what's happening, right? Now, that's very difficult for other studies, okay? But this, for the chest x-ray, is easy to do that. And so you can look at the study here, right, and match it to your metadata. If you are able to write some simple NLP that just split the study indication, priors, findings, and impression, you could just get those segments of the report and use those segments to do something else. And so the indication is the reason for the study, right? And so here we can have, for example, pneumothorax. You can see why real-world AI is very difficult. This is pneumothorax and a question mark. That just means there's concern for pneumothorax. It's not very obvious to a machine why this is this way. And then we always compare the priors. Some priors are given as a date. Some priors are given as a preview taken 1 week ago. Most of us would just use a date. And then the findings is what the radiology sees. And then impression is, I've looked at these findings, I've looked at the history, I think this is what's happening with the patient, okay? So the reason why this is important, and I'll show you some examples, is that some people, because of the compute before the what we're experiencing with the large language models, we just pick the impression to figure out, and there's that sort of sequential way of labeling. And so some people would pick up just the impression and use that for labeling. Some people would look at the finding section and use that for labeling. Some people would use both. And you can see why, if you use the indication, your model may say that there's pneumothorax, okay? And so so it turns that, at least in the era of the labeling, uh, most of these are rule-based systems that extract information from radiology reports, but they struggle with the linguistic nuances. Yes, hi.
What are some of the...
You're not allowed to ask me a question, but okay.
Yeah, ask the group.
Okay.
What are some of the challenges? What are some of the challenges if you use the findings section versus the impression section versus both? So this is worth thinking about, because your labels will define the quality of your model. I think yesterday we said data prep is 80% of the work. What happens if you use findings only, impression only, or both? So let's brainstorm a bit. Okay, so yes,
Yeah.
please.
Yes.
So I'm not a clinician, but I'm assuming that the impression field is a shorter, like quick synopsis of what we think is happening, whereas findings is a lot more detailed. Is that fair?
Okay,
Yeah.
yep. So findings is more detailed, impression is a short synopsis. What else?
Mhm.
Yep. Right. So the answer was the finding section may include artifacts or information about the image that doesn't make it to the impression section, but is still valuable. That's a very good point. What else? Okay, so that's a very good point. So what he said is that the different radiologists or healthcare practitioners may label the same image with different labels. Judy may think it's a pneumothorax and I may not think it's a pneumothorax. So that's a very good point. That's a separate issue, right? Is like what are we actually calling ground truth? It's actually just somebody's opinion. That won't change between the findings and impression section of a single report, because it's generated by one person. Yep. Exactly. Great. So the answer was that the findings is the entire thought process representing the image, and the impression is the conclusion. So all of those are very good points. I think you guys hit the nail on the head. The way that I would describe it is that the finding section is, in theory, going to mention everything that's visible in the image, whereas the impression section, what we use is what is relevant for the referring clinician to know. So in this example, let's say this was an ICU film, and there's a chest tube, there's a big pneumonia, there is two bilateral pleural effusions, and this is the third chest x-ray they've received today. So the findings section may say, redemonstration of bilateral pleural effusions, pneumonia, ET tube in place. The impression will say no change or no acute change from prior. So if you take no acute change as your label for this, or no change for your label, you may label it as a normal image. You didn't mention consolidation, infusion, etc. Right? So I think the best practice, if you had to pick one or the other, I would probably pick the findings section, but really you want to use the impression section and the findings section to get your labels out. So I think this is a really important nuance, not just for chest x-rays, but for any medical imaging, is like what the radiology reports come down to largely a radiologist's opinion about the case, right? We don't like to call it our opinion, but that's what it is. and it is imperfect. But the more descriptors you can glean from that, now with LLMs you can even do more than we used to be able to do, the better chance you have of getting the most accurate label for that image.
You should just stand here so we can co-teach. Okay. So the other thing that you have to be sort of careful about, and this was going to come at the end, is the long-tailed classification, right? The rare things, right? And here, if you assume truly, like the future, and this is a grand challenge, that AI serves to make things easier for us to help the radiologists, right? Then probably most of us would still catch the big pneumothorax, but that you want the AI, if you use just reports alone without validating it with the radiologist, then you want the AI that you still need to, the AI that says this is, let me rephrase, a report that is normal and represents a missed finding, right? That's where you want AI to shine, right? Because it's helping the radiologist, right? But those type of labels are not very easy, I think, to curate. Does that make sense? So you want the misses, the things that I've missed, but if you just relied on my reports, you would never know what I missed. You'd have to either, for example, correlate that I missed a lung nodule because someone got a CT scan 2 weeks later and there was a lung nodule. Okay, I know Harry has, and in one of our data sets will be end up being that way. Yes.
Excuse me, I'm not familiar with group work, so in my, not my, computer scientist, I don't know that much. So these findings mean that inversion, or these findings mean that it leads to that inversion, or it doesn't lead to that inversion. Right?
Yeah. So the findings section is, I think the way that you described it, the findings section leads to the impression, is the right way to think about it. The impression is not necessarily a summary of everything in the findings section, but it leads to the impression. So let me give you an example. So if we have a CT of the abdomen and somebody's looking for appendicitis, okay, in the findings section, we'll write the appendix is dilated, inflamed, hyperemic with surrounding fat straining. There is no free air. There is no abscess. That'll be the findings section. The impression section will say acute uncomplicated appendicitis. Okay, so we didn't mention, aside for the word appendix, we didn't re-mention any of those sentences or phrases. So the impression is like, here is my short synopsis of all of the things that I described in the findings section. So in this case, the lungs are expanded well, so they've taken a good breath. There's no consolidation, effusion, pneumothorax. The cardiac silhouette is normal. So I'm describing, in this case, everything that I see is normal. The summary of that is that there is no acute process, right? So it is not necessarily just a recapitulation of the same thing. It is like an interpretation of what you have described in the findings. And the phrasing, the words you use, they may overlap, especially if it's positive, right? If the finding section for chest x-ray says left lower lobe pneumonia or left lower lobe consolidation, the impression may say left lower lobe pneumonia, right? But that's not always necessarily true. So the phrasing and the language can be different between them, but they are meant to drive you to the same conclusion if you have the domain expertise to understand. So for the appendicitis example, if I'm a surgeon reading the impression and it says acute uncomplicated appendicitis, I know that that means the appendix is dilated, there's no free air, there's no abscess. So I know that because of my training, but you want to give people sort of an easier, more succinct thing to read, and if they need more details, they'll go back to the findings section.
And can we change the inversion because, or findings after, for example, the surgeon opens it and something
No,
like that?
the
No.
report doesn't change. So very rarely. There are some rare exceptions, right? If the radiologist missed something and the surgeon calls and says, "Hey, I see a little bit of blood or I see a little bit of air," you may actually make an addendum to your report as a radiologist. That would then be in here, but by and large, you don't change your reports. So that future ground truth is gleaned from somewhere else. So we'll talk about this in mammography. The mammogram report is the opinion of the radiologist at that time. They may send the patient for biopsy, but the ground truth for mammography is not really the radiology report, it's whatever the pathology said, right? We'll talk a little bit about that nuance.
Okay.
Yes.
Mhm. Yes. Yeah.
Yeah, thank you.
Mhm.
So the question is the indication field, the answer is the impression field, and the evidence I use to get to the answer in the impression field is the findings.
Yeah.
Ideally, but
Ideally.
but but rarely, and I'll tell you why. So I think that, so in an ideal state, the indication should be the question that you want answered. The impression is typically our answer to that question, but oftentimes, unfortunately, what we get in the indication section is literally
Nothing.
like nothing, or pain. You know, it'll be like an ER patient, it'll say chest pain, or it'll say pain, or it'll say shortness of breath, or for cancer patients, it'll just say cancer follow-up, right? So it's not inaccurate, but it's not really even a well-formed question, right? So for acute things, for ER patients, they usually are thinking of something that they, are looking for, and they may or may not put that in the indication. But for outpatients, right, it could be somebody's diagnosed with breast cancer, it's their 6-month follow-up abdominal CT, and it's just, follow-up known breast cancer. And so that's not really a question. We know what they're looking for, so we answer it. But if you wanted to turn into a Q&A paradigm for the indication impression, you would run into a lot of challenges due to the way
Yeah.
they just don't give us good information.
Yeah, and then also like in real world, sometimes because you don't have time to look through the EMR, Harry reads hundreds of studies in a day, so you just don't have time to go fishing. And so what you do is sometimes you can look at the prior reports, so you can kind of glean into what's happening. Some people can change the indication, if they find, like if it's a really hard case, you can go back and add more history from, because you, or the doctor came to the room and talked to you, and then now you have more history. Or you can also sort of like, if there was, for example, there was rapid ordering of tests, right? So there was a chest x-ray and, 5 minutes later there's a CT. Even if it's not been read, the natural thing would be to cheat with a CT to finalize your chest X-ray, right? So there's a lot of small changes that happen in just the way a report is generated, that when we just pick the report and train AI and say you're better than radiologists, it's a big stretch. Yes, Saptashi.
So one of the challenges you mentioned was that minor details get missed, or the AI to be useful to be able to get to it. So between what the resident wrote and what the staff handled, can you use that process to
Yes.
get to make your model better, because that's what sort of AI is, and then gets better
Yeah.
in the final.
Yeah, and I know that we've thought about doing this project. So what Saptash is asking is, now when you have residents, usually in the US, they start by generating a report before you see it. That's how we teach the radiologists, right? And they put their report in draft. Sometimes, depending on their year, they can find like, it's called a preliminary report, right? So it's not final. Sometimes it's very short. Actually, it's great for labeling, I think. It's very short. It's like, it's trying to say, look, doctor, your patient is crashing. There's nothing to be worried about on your chest X-ray. That's it. That's the purpose. It's not supposed to be very detailed. And so, but the challenge with that, right? And then in the morning, you have this thing called an overread. I think you should explain this better than me, you know. Yeah, so you have this thing called an overread that is now the final report. So reports have different status, and for us now, I do believe we have access to the database that can give you those type of reports. But remember, that data may not exist in your enterprise, right? And when I asked Chad to pull that data, he would never be able to pull it. I would have to get it from another database that is the voice recognition database, and if it's keeping snapshots of that information. So you can imagine amazing ways when we're starting to think, how could LLMs help with education, you know, those type of projects, or this teacher-student form of training to say, here is how the learning process works for radiology, and this is how you can use it to train an AI model. Yes, Monique?
So, yeah, we understand now the impression is not really a confirmed diagnosis, rather
Yes.
the judgment at that point. But more forward-looking in the future, since we will definitely be interacting with AI more, I'm just thinking, is it possible in the future that change the clinical workflow a little bit? When radiologists provide their impression, would it be possible they assign a confidence, saying that, you know, for this case, I'm very confident the result accurate.
Yeah.
Identify all these items.
So we kind of do that, right? So innately, because this is our opinion, we try to attribute our confidence in there by using language. So there have been many efforts to standardize the meaning of various phrases we use. So let me give you an example. So the impression could say findings. Okay, so let's go back to the appendicitis example. The impression could say acute uncomplicated appendicitis. Now, if a radiologist puts that down, that means they're highly confident. Let's call it like nearly 100%.
100%,
right?
yeah.
They may say, you know, highly suggestive of acute appendicitis. That's a little bit less confident, maybe 80%, 90%. They may say may represent appendicitis. That's like slightly better than half. And they may say cannot exclude appendicitis. That means I'm really not sure. I don't think it is, but appendicitis is such a life-threatening condition. If missed, I still want to bring it to your attention, and you go evaluate the patient, their labs, and you know, use your clinical judgment. So we do bake those phrases in. We say may, probably, possibly, suggestive, and every radiologist does it different. There have been papers to try and standardize that reporting system and say, okay, if you use this word, you mean this. If you use this word, you mean this. It's not really gotten a lot of traction just because I think it's a stylistic thing, and physicians are, you know, stubborn mules sometimes and don't want to change. So it can be tricky, and it comes down in the U.S. unfortunately to the medical legal. And I don't want to get too far off track. Part of the reason we say these things to attribute our confidence level is that if we end up being wrong and there's a lawsuit involving the case, it will come into play how confident you were about the finding, right? And there's a whole separate area of, you know, study around that. But if you say definitely acute appendicitis and you're wrong, you may get in more trouble or be more liable than if you say may represent or suggestive of and sort of say recommend clinical correlation. So that's a whole separate topic. I think the take-home message here is that volume, right, scale is our friend. So noise can sometimes be, if it's random noise, right, not non-random noise, but if it's random noise and some radiologists miss a small pneumothorax and some radiologists don't, then you can circumvent that noise issue with scale. And that's kind of what we're relying on. That's part of the reason that we need so much data.
Yeah.
We'll move on in the interest of time.
Yeah, but this discussion is so important because it's going to ground you in what's the state of the art right now for labeling, right? So we've discussed a lot about this I just want to show you this part of the sentence, like there's no sign of focal consolidation, effusion, or pneumothorax. That makes sense to everyone in the room, right? That these three things are missing from the report. But for AI, for NLP systems, it's so difficult because they will only catch the no sign of consolidation, and then the rest they'll assume they're present, right? So negation is the king for trying to figure out what's the appropriate label to do. So the NIH dataset was trying to do this, right? To show that they can use this weekly supervised. And then remember I said that to label the datasets, people said, show me like you go to a radiologist, which is not really the right way to do this, and say, here, show me the 8 conditions that we should label our data set. And so this is the example, another example, sort of like the example for the problem of negation, and then an uncertainty, as we discussed, in sort of like the confidence of the radiology. So what they did is that they used these two things called DNOP and MetaMap. And what these are, this is an example of DNOM. SNOMED is a terminology, right? Just the way you speak English or another language. SNOMED is the language of medicine, okay? And so, they started to correlate, for example, atelectasis could be represented in these concepts. Effusion could be this concept. And you can see why this can be a problem, right? Because pericardial effusion and a pleural effusion are very different things, right? And this is going to be a problem because pericardial is around the heart, pleural is around the lungs. Very different diagnosis. But when you sort of do this mapping, you can see sort of like what are the subsets. Then they went back and try to label them. So they looked at the findings and the impression section of the report, and if the report did not contain the 8 categories, they looked at the whole length of the report and just look if they did not have any of the 8 categories were processed as normal. And I'm not going to go too much into the details of the NLP. So they look at label correlation, like if you have, for example, an infiltration, then it can be correlated with effusion, it can be correlated with atelectasis. This is an important piece, and I'll show you how we do it now. And then they sort of had a quality process, right? Because you have to go back and say, again, what's the radiologist? That part is still a gap, I would say. And so they compared it with the OpenEye dataset from Indiana, which has human annotators. So when you pick your dataset, figure out, you may just see labels, but at least you should do the work to figure out, is it human annotators? And human annotators means you give them a chest x-ray and you say, label. Okay, and they don't dictate, you just give them a list of the labels and they come up with the labels. Usually and we've done this, and I'll show you sort of our experience doing this type of labeling. And so they were using sort of like the OpenEye data set and then trying to say what was the precision, recall, and the F1 score of the method for producing the labels themselves. And so I'll show you they noticed that their improvement, which was the contribution, was that when they used negation and uncertainty detection, that they ended up removing the false positives. So here is sort of an example of a bounding box. A lot of people there's quite a lot of intersection using the saliency maps, which are just show us where the model is looking and trying to like narrow it down, that's where the abnormality is. And bounding box are easier for radiologists to do. They can do them faster. Really, to me, if you can label some subset of your data set that way, it's better. I can tell you that we've used, for example, publicly available data sets with bounding boxes and used that, converted them to classification tasks to do our labeling for our own data set. And as they reviewed, of course, they found out that there was a problem and they needed to capture more labels, which included consolidation, edema, emphysema, fibrosis, and hernia, and no findings. And this was pleural thickening. And so then they updated the labels. So this is how the chest x-ray 8 became chest x-ray 14. But you have to be careful because the next data set, CheckSpot, also has 14 labels, right? But they're not overlapping. So if you match those two data sets, or you're trying to do a multi-class label prediction, you have to, they're not overlapping. You have to see what of the new labels match. So TechSpot came 2 years later in 2019, and this was looking at the prevalence of, instead of just asking the radiologists, they were looking at the prevalence in the reports and the clinical relevance. And this is, there's a society called the Fleischner Society, and this is has a recommended glossary of things that can be there. And so, they included pneumonia because they felt that this, even if it was a clinical diagnosis, it was, it just suggested a primary infection. I can tell you in the era of COVID, people have said, well, should you just say pneumonia or viral pneumonia, bacterial pneumonia? You see, sort of like the complexity of labeling. And then if you if you did not have any of the pathologies, then you had a normal chest X-ray. So their model gives a probability score. They look at both views when available, the PA and the lateral view, and then they give you sort of like, oh, what are the chances of the disease of across all labels? So I would call this as a normal chest X-ray, and you can see sort of like the overall probabilities are, well, it says there's a pleural effusion. I don't see it, but yeah. So but this is sort of like how their model works. So these are the 14 labels from TechSpot. So if you're using this NIH dataset and the TechSpot dataset, you have to go back and sort of make sure that everything is matching. So for example, fracture does not exist in the NIH dataset. And since the NIH dataset does not have reports, then you cannot add new labels, right? And so this TechSpot labeler became the gold standard now for labeling chest X-ray dataset. So the MIMIC chest X-ray dataset, and even subsequently last year for the Emory dataset, we used the TechSpot labeler. It's one of the, yes. Yes. Uh-huh. Mm-hmm. Yes. Yeah. So so the question is, if you're quantifying size. So let me clarify, here is just a probability of present or absent, right? So, but if you want size, the way to do it would have to be a segmentation task, right? So then you get a volume, and then you look at the distribution and say, this is the highest volume and this is the lowest volume. But it would require so much work that no one would be able to do that. Yeah. So right now, the only way you can do it is just trying to, you can also have radiologists look at the images to do something like that. So here's an example of sort of like the TechSpot labeler. So this is a report. These are just findings that are pulled out, and remarkable cardiomediastinal silhouette. So you can see that for enlarged cardiomegaly, the labeler puts 0. Diffuse reticular pattern, which can be seen with a typical infection or chronic fibrotic change, no focal consolidation. So this is that type of report that's very, you're not confident, and so you can see consolidation gets 0, and but there's a lung opacity based on this gets 1, and then no pleural effusion or pneumothorax, so pleural effusion and pneumothorax gets 0, and and then because of just sort of like the hedging a little bit for pneumonia, it gets an uncertain label. So everything gets a 0, 1, or a mu, and mild degenerative changes and all right rib fractures, so fracture gets 1. So this is, when you run TechSpot on a report, this is the type of thing you'd get. And so you have to, yes. Okay. So you have to get some form of radiologist to look at either the report or images to tell you how good your labeler is, right? And so in this one, they looked at 3 radiologists who annotated the set using radiographs, and then did again from 5 radiologists. So they had quite a lot of people looking at this, and this is why most people will start off with a TechSpot labeler. And so the way they did this 3-stage, they looked for the extraction, anything that is mentioned in the impression, and then they classify it as negative, uncertain, or positive, and then they aggregate the results. And you can see sort of the NIH dataset versus the TechSpot dataset. So these are the shared labels. These ones don't exist in the NIH dataset. Yes, Amina? No, just the report. Yeah. Okay. So if you need the image, you have to have a radiologist do it, but I'll also show you some new ways of annotation. Okay. So, so in your model, you have to decide how you want to deal with uncertainty, because this is what, as the earlier discussion was showing, some people use the ignore method, and this is just to ignore the uncertain labels during training. And then some people either convert the uncertain ones to zeros or ones, depending on how you process it. And then other people can also do like a sort of classification where you predict 1, 0, or a mu. And so what they observe is that there's variation in terms of the conditions that are predicted, whether you conform to like a mu 0, is good for atelectasis and cardiomegaly. But you don't have to worry about this because this is included in the TechSpat, package, right? So that's available as code that you can do. I want to show you an example here, but we've discussed it, that, for example, most cases for cardiomegaly tend to be borderline. So, for example, minimal cardiac enlargement would be something like, it's borderline. Some people now could go and try and do the contour of the heart and then, measure it with the other diameter to get an exact ratio, right? And but it's also very difficult to characterize, for example, when the heart is mentioned in the findings, for example, unchanged appearance of the heart or stable cardiac contours. To me, this would be, based on the labeler, they can either end up being negative or positive. So this just a practical example to show you the challenge. So the QC process, right, looks at, and when you use a data set, at least you should look at these components because it has such an impact on how you do your own work, right? And so they picked 200 studies and then had 3 board certified radiologists look at them and label them and then compared the performance. So, and then they had another group of 5 radiologists. And so they ended up having a total of 8 radiologists. And you have to adjudicate their disagreements, right? And you have to report it in your data set to say, and how that was resolved. Now, I showed this. These are 5 conditions, sort of like the performance and where the radiologists were performing, right? So you can kind of, see sort of like there are some people who are very low performing, some people are high performing, and it gives you a sense of how your radiologists are doing. But I show you these 5 conditions because if you have a project today, for example, for bias, most people don't want to do the 14 labels, right? Most people want to pick 5 labels to show your use case, and these tend to be the 5 labels that are picked because in terms of they're adjudicated to be the most common, and if you're saying, I'm going to show metrics of bias, then it tends to be that you're picking these 5 labels for your project most of the time. And then, differences between the NIH and TechSpat dataset, TechSpat labeler, which resulted in the TechSpat dataset, is it did not use these automatic dictionaries like MetaMap or Denom. And then the TechSpat incorporated these several rules to capture variation in negation and uncertainty, which is why they ended up with a better performance. And, and then there was this concept of pre-negation and post-negation, which is also looking at how the radiologist performs and sort of like when you resolve this. And then, for example, this one cannot exclude pneumothorax, conveys uncertainty in the presence of pneumothorax. But without the pre-negation stage, the pneumothorax would have been classified as negative because of the exclude pneumothorax. So just the language is so important if you're going to use radiology reports for labeling. So we did this for last year's datathon, and then in the process, as people worked on it, we started to capture some problems with the data set. And this, yesterday we saw that F1 score of 0.99 is an error, right? F1 score of random or less than 0.5 is another error. You should be figuring out what's going on. And this became our pneumothorax at investigation that showed that we had problems with the TechSpat labeler performance on the Emory dataset. And a lot of work was done by Frank and Theo, who are our postdocs, to really go back and, number one, come up with, use like the ACR dataset, which has human annotations, which are segmentations, to use that as the ground truth to train a model for pneumothorax and then do inference. Those words should be making sense for everyone because of yesterday, right? So do inference, come test the model on the Emory dataset, then that's based on the image, and then see where does the model say this is positive, and where is the model image versus report discordance, and then review that and fix that. It brought a lot of projects for us, just sort of that investigation and trying to figure out that error. And so we're doing a lot of LLM-based labeling, and actually there are a lot of papers about this, and we use the FIA, and we relied on chain of thought prompting. We started off with the mimic dataset because, again, you know, it's you already have some labels, and there's also a candid a pneumothorax dataset that has expert pixel level annotation. So whatever chest X-ray is the go-to. If you have a machine learning concept in medical imaging, you start off with a chest X-ray dataset. But I hope by now you'll understand sort of like how should you get started. And if you're like Maria, who's going to curate their own datasets, how do you sort of, what's the gap, and how are you going to decide how much effort you're going to do? So we've seen better performance around this. You know, this is the TechSpot labeler and the LLM sort of labeler, and sort of this absent, present, and you know, so we had a little more, you know, and negative labels. You know, again, the same metrics that are reported, but we found that you know, that the LLM-based labeling depends on model size, the prompting technique, and the task difficulty. So for example, this is an example. When you say skin fold projecting over the left hemithorax should not be mistaken for a pneumothorax. That's very obvious to people in the room. You'd label this to be negative, but the TechSpot labeler says this is positive, right? And then if you look at this left pigtail catheter, large perfusion with small hydropneumothorax, that means you have both air and fluid, right? And you can see that the LLM labeler, because it's so specific, decides that this is negative. So there's so many small nuances that you have to do. So trying to wrap up so we can go get our picture. There's something about beyond the 14 labels, and there's this work done by Lauren. She's just an amazing researcher. You should read about her work. And this is hidden stratification, causes failures in machine learning. And so there are sort of 3 ways in terms of hidden stratification. Usually it's because it arises because of subsets with low prevalence in the dataset, or low label quality, or subtle distinguishing features, or spurious correlates. And so this can result in a performance difference of up to 20%. And so you can either, how you resolve this, you can either say, complete the schema, which is say, give all possible labels that can, now people can have 100, right? Who's gonna label for you 100? Nobody will do that, right? So it's a weird negotiation about what you should try to focus on. People can do, you know, error auditing. You should use this as a toolbox when you're just getting a model, you have a new data set and you do inference, and then you're like, oh, there's a drop in performance, right? So, you know, and then you can measure sort of like using clustering, using algorithmic measurements. And so, you know, these first 2 are very labor intense, and you'd have to just be working in that space. The other way to do it today, if you're just starting work in this space, is to look at what's been published. And just try to exact the labels. So hidden stratification is, you have this small, for example, emphysema is one category that is provided, but you can have emphysema in the lung, or you can have emphysema in the subcutaneous tissues, right? So if I stab Harry, he likes to almost knock me with his car every time, but if I stabbed him, you'd have air in the subcutaneous tissues, and that's called subcutaneous emphysema. Those are very different diagnoses, but because your label is emphysema, and it just, they're all grouped together, right? And so, you know, so what Lauren did is to look at pneumothorax and say, this is the overall AUC performance of the model, the blue line here, 0.87. But when you split people who have chest tubes or no chest tubes, right, this is an amazing thing. You should try and do this during the datathon to figure out these types of failures. These are really open, and they're just low-hanging fruits to do this type of work, And so if you look at this, if you look at the chest drains, the model starts to perform way better than the baseline, right? Because it's having a shortcut. It learns that if you have a pneumothorax, which is air around your lung, we treat it by putting a tube, right? So that's the easiest thing for me to learn. So it learns that. And then the harder case, which is this one without the chest drain, which is the one the radiologist needs to know about because it's not being treated, right? The model even drops in performance. And you can see sort of this also when you just have hardware present or not, normal, abnormal, you see this performance, but when you bring in fracture and degenerative changes, you see a drop in performance because of the hidden stratification. And so I mentioned that you can do radiology reader studies. They're expensive, so be very smart about how you do this. So Harry did this for us during COVID. We had 10 radiologists. You have to capture what they read. If you are trying to look at performance in the emergency room versus, chest-trained radiologists who only read that modality, obviously there can be performance differences. You have to look at these are some of the metadata you have to look at. And this just shows a big spread, right? There's no very difficult for us to just annotate normal COVID positive, COVID-19 positive, other infectious and other non-infectious disease. And it's much easier to label normal studies from a radiologist's perspective. You have to do your reader agreement studies, and you can see that there's still variable performance across all the, the images and the radiologists. So there's quite, how you look at this is called the Kappa score, and that gives you the agreement between the studies. So if you spend all this work, you should use that for your test set. You should not be using that for your training. That's our lesson. And so I show this to reiterate that another way to label chest x-rays is not only to look at the chest x-ray itself, but you can use a lab to label, right? Like COVID, RT, PCR test. And it can be positive, but that does not correlate to findings in the lung, right? So you can have COVID positive patient with a normal chest x-ray. Okay, so just be conscientious about the source of the label that you did. So I told you the inspiration of this was the Singapore Datathon from Moning, who's sitting there, that ending up with this paper for us for AI can predict the race of patients from chest x-rays, right? So just because a label doesn't exist, it can still be included, and I'll show you some of the new things that we know that can be predicted from chest x-rays, and that these findings persist even when the images are very altered. And we couldn't figure out why. We still haven't. So it's around 2 years later. A lot of papers have been published about this, but there's no real one way for us to figure out why, and it's not because of our confounder. And so a lot of papers have been published to say predict age, predict healthcare expenses. And I like to summarize this as, if you had my chest x-ray, you could say I'm Black, because that AI can say. I'm female. We know that AI can do a good job with that. And you could say my chest x-ray age is 78 years, which means I'm aging faster than my real age. And my social deprivation index, which is just a mark of where I live in terms of health impoverishment, can be encoded on the images, and this is high. And I have COPD and congestive heart failure, and I'm going to spend $15,000 in the next 1 year. This is a big problem. This is one of our big things that we work on here at the HITI lab, but we don't know why. And it requires many, many people to look at the explanations, the things about data sets, because some of these things are not biologic things, so they shouldn't be possible. And I hope that as you go along through the week, you're going to reflect on how can we design much better studies to answer this, and brainstorm so that we can try some of the ideas as we come throughout the week and as we come to the weekend. And so, I said that AI can tell you who has diabetes from your outpatient screening, right? So this concept of opportunistic screening, I think one of the hottest areas of research now, and you can tell who has a 10-year cardiac risk, who has type 2 diabetes, what's the ejection fraction. These are not labels that you'd ever find in a radiology report, right? These are labels that exist because you merged an echo with a chest X-ray data set, or you merged it with something different. Pancreatic cancer, on images that are odd, Theo and Harry work a ton with using cardiac prediction risk from mammograms. So I think you're gonna see, sort of like the setup. If this is of interest, you can reach out to both of them. And it's envisioned that in future, it may not be just the chest X-ray. The referring doctors may get this report that just says, your chest X-ray indicates that you have type 2 diabetes, your coronary calcium score is this, your ejection fraction, and your heart risk. So that there's so much metadata encoded in the images. I like to call this as hidden signals, but we don't know how to use them. When are they reliable? When are they going to fail? And we need a ton of work. It's an open area for research to explore this. And so this is subsequent work. As I mentioned, we noticed that there's a problem with the Emory's chest X-ray data set. And we went back to, should we use we did some human annotations for around 2,000 reports, and then we went through CheckSpot, different types of LLMs, the VIA, Llama, and Phi, and what we observed is that the models are actually very forgiving for dirty labels in training. And in fact, based on our work, I suggest that you just figure out how to use, even if it's LLMs, for your own, and QC for your own labeling for the training data set. And then for the test data set, you invest in the human annotators, because they're expensive. And so the models seem to be very forgiving. And for the radiology report, because it's short, it turns out that the lighter models, those can even run on your laptop, are okay for these predictions. And so, you should sort of, I think that's been a good lesson for us as we move forward. And, we do this a lot of label correlation, and it's important as you think about, if you don't have, you only have 10 cases of a certain condition, you have to look for them in other data sets. Remember yesterday's talks around the complexity of the views and those other small things that you should think about data harmonization. But if you look at the 3 data set, you can do this correlation matrix, and you can start to see, for example, anything that's coming higher here is correlated, so for example, pleural effusion and lung opacity, and that clinically would make sense. This is also a good way for a sanity check for your domain expert, right? Because I want you to walk out of this week to be able to talk to your domain expert. And if you show the label correlation matrix, they can quickly say, oh, why is that correlated with something else? For example, if the no finding, which is the normal chest X-ray, was correlated with something else, then I would say we have a problem. We have a problem with our labels, right? And we can quickly audit those type of cases, because your domain expert is not going to have all the time in the world to look at all your images. You have to be smart about what information and what question you're asking them. So you can see that there's variable, correlation and across data set, and that for us, we found that the CheckSpot it tends to be an outpatient data set. Mimic, we know that it's an ICU in hospital data set, and the Emory data set is this. And for example, you can see that in our labeler here, no finding, we see quite a lot of support devices, and it's a little bit that the no finding sometimes is used for no acute abnormality. And yeah, so finally, you can use AI to label data sets, right? So for example, if you have 5 good models that can pick normal, you can just run them on your data set, and then you say, if these are normal, it's probably normal. I think it's an interesting way to do it. I mentioned about shortcut learning and why this is a pitfall. This work is done by John Zek, who showed that pneumonia, AI cannot tell what pneumonia is. It just learns the radiographic marker in the radiograph and predicts that this is pneumonia. So there's how your what is on your data is very, very important. This is a really good paper you should look at if you haven't. And this is for COVID and showing the challenges of composing new data sets. and how you can use like external validation to show problems in terms of your labels. And that if you change the last layer of your model and say predict the projection or the patient sex, the model can encode those information just because they don't exist in your ground truth. And I do use this as a trick a lot with my students to try and say, okay, just predict something to show us robustness of the model. Here I mentioned that, if you have pneumothorax, we put this chest tube for treatment, and those tend to full models. Here are examples of other shortcuts. These are knee radiographs, and if you just train a model to tell me what's the source of the hospital, there are 5 hospitals. You can see that there are different radiographic markers everywhere, and some have bounding boxes. The model does a really good job to just tell you what the hospital source of the image is. And what it's looking at does not always correlate to where the radiologist will be looking at. So this is also this discordance of models. So, in summary, I think I explained to you sort of like why the 14 labels and how to think about it. And most of the time, you probably will pick the 5 top labels and what those labels are. I went through this NLP rule-based system to check spots to now sort of like the LLM label. And we have this concept of hidden stratification, which is a big, big challenge and needs to be solved. We have how to conduct a reader study. There's the lab-based labeling and the labeling for opportunistic screening, and sort of thinking about label quality and label correlation, and how to use models for ensemble labeling, and this concept of shortcut learning that can encode things that you don't explicitly provide into your model. So a lot of work, open questions. Enzo here does the same type of research, so you can get new ideas just by looking at this. So we're not going to do the demo, but this is it. We've really streamlined our process of using LLMs and new prompts, and just spend some time looking at it. Theo and Awez here worked a lot on this, and Badia, who's not here. So if this is of interest or you want to do a project on this, let me know. So thank you. I hope we are 12 minutes late than our picture. So any questions? Yes. Yeah.
So, should we say that the system best mimicking the radiologist instead of it gives the real answer?
So I think most people would say that this is weakly supervised labeling. We understand it's not the optimum, but it turns out that the models still learn pneumothorax, even when you have errors in your label. They still learn the disease that you intended. So like Harry said, it's about scale, right? If you have more data set, more labels, it's probably gonna be okay. Okay, ready for a picture? Yes, I am ready for a picture.